we will start talking about diseases of the esophagus, first parts. Before we start talking about diseases, we want to have a brief overview of the anatomy and the histology of the esophagus. As you all know, the esophagus is considered a muscular tube extending from the epiglottis superiorly to the gastroesophageal sphincter inferiorly, and it is lined by stratified squamous epithelium in normal conditions. As you can see here, you you can notice the normal esophageal mucosa, which have a tan color, as you can see here, in contrast to the normal gastric mucosa, which has a light brown color. In normal conditions, this is the normal color of the esophagus, tan to pale pink color. Here you can see the normal lining of the esophagus, which is a stratified squamous epithelium, and then underneath which submucosal layer, as you can see here, and here you can see the muscularis propria layer. Diseases that affect the esophagus are subdivided into 4 categories: those that cause obstruction, whether mechanical or functional; those that are vascular, like the varices; and those that are inflammatory, we call them esophagitis; and tumors. First, to start with mechanical obstruction, which can be congenital or acquired, the 4 first conditions are usually congenital, like atresia, fistula, duplications, and agenesis. Agenesis means that the esophagus is not developed at all, and it is a very rare condition. Atresia, fistula, and duplications can occur, and usually they present shortly after birth, and they are non-compatible with eating and drinking or swallowing food. Stenosis is considered another cause of mechanical obstruction, but most of the cases are acquired. Let's start with atresia. Atresia means that a part of the esophagus is non-canalized, and it is replaced by a thin cord. This will interfere with the swallowing process and causes a mechanical obstruction. Most common location is at or near the tracheal bifurcation, and sometimes it is associated with a fistula that can connect the upper part of the esophagus or the lower part of the esophagus with the trachea or the bronchus, with consequent risk of aspiration and aspiration pneumonia. As you can see here in this picture, we can see here the normal anatomy, in which we have a full esophagus separated from the trachea and the bifurcation of the trachea to 2 main bronchi. Here we have an atresia. This white color here, it means that this part is non-canalized. This is the proximal pouch, and this is the distal pouch, in which it is connected by a fistula to the trachea. The second scenario, in which you have both proximal and distal fistulas from the proximal part and the distal part. Here you have a fistula connecting just the proximal pouch to the trachea, and here we have an atresia without fistula, and here we have a fistula without atresia. The clinical presentation, as I said, they usually present shortly after birth with regurgitation of food during feeding, so this is non-compatible with life, and it needs prompt surgical correction to rejoin the parts of the esophagus in order to for the baby to be able to eat and swallow. The complications, especially if it is with a fistula, is aspiration of food contents, which can be complicated by suffocation, اختناق, or by pneumonia, and severe fluid and electrolyte imbalances because of the inability to eat and the nutritional problems. Esophageal stenosis is considered an acquired cause in most of the cases. It is characterized by fibrous thickening of the submucosa and atrophy of the muscularis propria. And this will cause an impedance to the flow of food through the esophagus. This stenosis is usually due to an inflammation and scarring upon a previous injury. The causes of stenosis, most of the time, sometimes it's chronic gastroesophageal reflux disease, which could be associated with ulcerations that are repaired by fibrosis and will lead to stenosis and narrowing of the esophagus. Patients with systemic sclerosis because of the fibrosis of the submucosa, patients who are exposed to irradiation therapy أو those that ingest caustic agents اللي هي المواد الحارقة like acids or alkali. They can cause chemical esophagitis which can be complicated later on by fibrosis and stenosis. The clinical presentation is usually a progressive dysphagia that starts for solid, then it progresses to even problems with drinking liquids. The second type of obstruction is called functional obstruction. The functional obstruction in which you do not see something that interferes with the passage of food, but there is an abnormality in the innervation. As you all know, efficient delivery of food and fluid to the stomach requires coordinated waves of peristaltic contractions. An esophageal dysmotility leads to discoordinated peristalsis or spasm of the muscularis propria of the esophagus, and this will lead to inefficient delivery of food through the esophagus to the stomach. Achalasia is the most important cause of functional obstruction. Achalasia is characterized by a triad of incomplete lower esophageal sphincter relaxation, which means that the lower esophageal sphincter muscle tone is increased and there is no complete relaxation of the sphincter, so the sphincter will be a semi-closed one. In association with esophageal aperistalsis, which means that there is no peristaltic movements. Primary causes of achalasia are much more common than secondary. As you can see here, this is the lower esophageal sphincter here, and the tone of the sphincter is increased, so it is semi-closed. It will not open and will not be completely relaxed upon the arrival of food, so the food will accumulate in the esophagus and the esophagus will dilate. This is the typical feature in achalasia. As you can see here also, this is a barium swallow in which the patient is asked to drink barium and then an x-ray is taken. As you can see here, the gastroesophageal sphincter is as a ring, as a string sign. It is semi-closed with a passage of very minute amount of food through this sphincter to the stomach. So the food will, or the barium here, will build up in the esophagus and which is dilated. Primary achalasia is caused by degeneration of the distal esophageal inhibitory neurons, which are responsible for the inhibition of the contractions and will lead to the dilatation or relaxation of the muscles. So the degeneration of these neurons will lead to increased tone of the lower esophageal sphincter, and in most of the cases it is idiopathic, and it is the most common cause of achalasia. Secondary achalasia, which is less common, lakin it is associated with loss of a neural innervation to the esophagus due to the damage in the esophagus itself, in the vagus nerve that innervates the esophagus, or in the dorsal motor nucleus of the vagus. One of the causes of secondary achalasia is Chagas disease, which is caused by an infection by Trypanosoma cruzi, which leads to the destruction of the main plexus and failure of lower esophageal sphincter relaxation, leading to esophageal dilatation. The clinical presentation usually starts with difficulty in swallowing and regurgitation of food, with sometimes accompanying chest pain due to the aspiration. Third, the vascular diseases, and the most important vascular disease of the esophagus is the esophageal varices أو دوالي المريء. It is characterized by tertious dilated veins within the submucosa of the distal esophagus and the proximal stomach. The diagnosis is usually performed by endoscopy or by angiography. As you can see here, these are the dilated submucosal veins engorged here with blood, as you can see in the distal esophagus. The pathogenesis is usually due to a portal hypertension. As you know, the GI system is characterized by the presence of a portal circulation. The portal circulation means that blood that collects from the gastrointestinal tract will not go and directly to the inferior vena cava. Instead, it will go through the portal vein to the liver for the detoxification of materials, and then it will go through the hepatic vein to the inferior vena cava. Any disease that impede this portal blood flow will lead to portal hypertension and will lead to shunt of blood from the portal circulation to the systemic circulation through the areas in which we have a collateral anastomosis between these two circulations, and one of these sites is the distal esophagus proximal stomach, leading to esophageal varices. Portal hypertension leads to the development of collateral channels in the distal esophagus, and as I said, it will lead to shunt of blood from the portal to systemic circulation. These collaterals will be dilated and will appear as varices. This is a diagrammatic presentation of the portal circulation in which the blood collects, as I said, from the GI tract, and it goes to the liver through the portal vein. Then it will go through the hepatic vein to the inferior vena cava. The causes of portal hypertension are usually due to cirrhosis, and the most common cause of cirrhosis is alcoholic liver disease worldwide. Hepatic schistosomiasis is the second most common cause. And this is what I mean by cirrhosis, in which the liver is transformed into a nodular liver, leading to portal hypertension. And those patients will also have a chronic liver failure. The clinical features of varices, they are often asymptomatic and discovered incidentally during endoscopy in patients with cirrhosis, because they should have a periodic surveillance for the development of varices. Rupture of these varices will lead to massive hematemesis and death. And what is the meaning of hematemesis? It is the vomiting of blood. 20% of patients will die from the first bleeding episode, despite the interventions, and usually death happens due to hemorrhage, hepatic coma, and hypovolemic shock. Rebleeding can occur in those that withstand the first bleeding in 60% of cases. The fourth disease of the esophagus is called esophagitis. It means inflammation of the esophagus, and the causes of this inflammation is esophageal lacerations, mucosal injury, infections, reflux esophagitis, and eosinophilic esophagitis. First, we will start with esophageal lacerations, and Mallory Westers are the most common. They occur due to severe retching or severe vomiting, why they occur? Because during vomiting, which is severe and prolonged, there will be no time for the esophagus to relax. So the passage of this large amounts of gastric contents through the esophagus during the vomiting will lead to distension of the stretching of the esophagus, which will lead to a tear. They usually present with hematemesis, which is vomiting of fresh colored blood. These lacerations are linear. They are longitudinally oriented on the gastroesophageal junction. Actually, they cross the gastroesophageal junction. They are superficial, just only in the mucosa, and they will heal quickly with no any surgical intervention. So when the patient presents to you with a vomiting of a fresh colored blood after a forceful vomiting, this is the typical scenario. You reassure the patient that will not happen again, and the bleeding or the tears will heal spontaneously. Chemical esophagitis is due to damage to the esophageal mucosa by irritants. These irritants could be alcohol, could be corrosive acids or alkali, could be excessively hot fluids, heavy smoking, medicinal pills like the doxycycline and the bisphosphonates, which is the major culprits in medicinal pill esophagitis, due to sometimes the large size of the tablet, which could stuck in the esophagus. That's why we ask the patients when they drink such drugs to swallow or to drink plenty of water and to stay in an upright position for a while. Iatrogenic causes of chemical esophagitis like chemotherapy, radiotherapy, and graft versus host disease. Chemical esophagitis can cause ulceration to the esophagus. تقرحات with acute inflammation and sometimes with a self-limited pain which is called adrenophagia, that is pain with swallowing. Can be complicated by hemorrhage, can be complicated by stricture, which can lead to esophageal stenosis, as we mentioned at the beginning of the lecture, or perforation in severe cases. The third form of esophagitis is the infectious esophagitis. Infectious esophagitis can affect normal individuals, but it is mostly witnessed in debilitated or immunocompromised patients. The most common causes are viral or fungal esophagitis, a viral esophagitis like herpes simplex virus and cytomegalovirus. Fungal esophagitis candida is the most common one, but it can be due to mucormycosis and aspergillosis. Bacterial causes of infectious esophagitis are much less common and they constitute only 10%, and sometimes they can be secondary infection in fungal and viral esophagitis. Let's start with candidiasis or candidal infections, which are characterized by an adherent gray-whitish pseudomembranes to the esophageal mucosa, as seen during endoscopy, and it is composed of, these membranes are composed of matted fungal hyphae and inflammatory cells, which we can see them microscopically upon biopsy examination under the microscope. As you can see here, this is the esophagus, and these are the whitish membranes, adherent membranes. The doctor who performs the endoscopy will tell the pathologist that I see an adherent whitish membranes. As you can see here in the oral mucosa, the infection also extends to the oral mucosa with an oral thrush. Under the microscope, we can see these hyphae. We use usually periodic acid Schiff stain, PAS stain, to highlight fungal hyphae. Herpetic infections or herpes virus infections are characterized by punched out ulcers, which are seen usually on endoscopy, and histopathologically they are characterized by the presence of degenerated epithelial cells, squamous epithelial cells at the ulcer edge. These epithelial cells show nuclear changes in the form of nuclear viral inclusions, and we can see also multinucleated epithelial cells in which the epithelial cells fuse to form a one cell with many nuclei. As you can see here, this is the punched out ulcers, which are seen during endoscopy, and here as well with surrounding erythematous mucosa and the esophagus. As we said from the start, that the esophageal mucosa is usually pale pink in color, but here it is erythematous and red. These are the multinucleated cells in herpes simplex viral infections. The nucleus, the cell will have multiple nuclei, and here as well there are multiple nuclei. The cells are degenerated, as I said. This is another view for the multinucleation. As you can see here, the nuclei are characterized by the presence of an intranuclear inclusions. Maybe you can't see them very well, but this is a typical feature that we see in herpes simplex infection biopsies. Cytomegalovirus infection is characterized by shallower ulcers, not punched out ulcers, and the biopsy will show both nuclear and cytoplasmic inclusions. The infection is usually here in the capillary endothelial cells and in the stromal cells. These cells will appear very large, megacells. That's why the virus is called cytomegalovirus. As you can see here, this cell will having nuclear inclusions. Okay, and this endothelial cell also here is very large. This is a stromal cell. Cytomegalovirus tends to infect also stromal cells and endothelial cells, not epithelial cells only as in herpes simplex virus. And thank you for listening.